Hello, TEP community. I believe we are all doing well. Good morning, good afternoon, good evening, good night, wherever you are joining me from. It's nice to have you today. So today we still have with us Dr. Grace. And if you watched my last episode, you know she took us through PCOS from a medical point of view. And there's so much we have to know. So today we are continuing our session, and we are privileged to once again have with us Dr. Grace. Welcome, Doctor.
Thank you very much.
God bless you for joining us again.
It's a pleasure.
Right. Today I would want you to tell us, are there types of PCOS? Do we have various types of PCOS?
Okay, thank you for that question. So it's very interesting that in all of my medical study, I have never come across types of PCOS. And when I was preparing for our interaction today, I came across some information that although it's out there in the public domain, is not something that is supported by the guidance under which people that look after women's health in the UK work under. So we know that there is PCO and PCOS. Those are the two main things that we know, that an individual might have polycystic ovaries without necessarily showing symptoms of the syndrome. And an individual may have polycystic ovaries and show the symptoms of the syndrome, in which case we classify them as PCOS. But as I said, I've come across some information where people are grouping PCOS into 4 or 6 types, dependent on how they want to look at it, sort of considering it from the mechanism of action or dysfunction. And I found that very interesting. So they talk about an insulin-resistant PCOS. They talk about an inflammatory PCOS. They also talk about a post-pill PCOS, and then they talk of adrenal PCOS. Now, let me just say it again, that this within medical practice is not something that we define by. We do know the mechanism by which PCOS expresses itself. And you'd realize that all these subtypes, so to speak, are part of the mechanism, not a type in itself. So in an individual, insulin resistance, which basically is how the body is unable to recognize the hormone insulin and use it, can feed into how their PCOS expresses itself. And that to us is not a subtype, it is a mechanism of the disease expressing itself or the syndrome expressing itself. So I am hesitant to classify subtypes of PCOS because it's not something that in the RCOG or NICE, which are the guidance by which we work, supports.
That's very interesting, Mami. That's very, very interesting. Thanks for clarifying that, because as you said, I've also seen information out there where people say there are various types, and those you mentioned are what they are also saying. So thank you very much for clarifying this for us. So it's either you are PCO or you've got PCOS. Thank you very much for this clarification. I would then also want to ask you, how can one tell, first of all, how can one tell if, no, I think you have said already the PCO. So how can one tell they've got PCOS, even without having been diagnosed?
Yes. So the way we diagnose PCOS is on the expression of the excessive male hormones as one criteria, the blood test that we do as a second criteria, and the ultrasound evidence of numerous or multiple cysts in the ovaries as one criteria. So there are 3. And if you have 2 of the 3, we diagnose you as having PCOS. The interesting thing is that you wouldn't have access to the blood test until you go to the hospital with certain signs and symptoms. Neither would you have an ultrasound look at your ovaries. So it's mainly about the expression of the excess male hormones in the body. And this we see in the irregular or infrequent or completely absent periods. That is often the main thing that would cause ladies to seek some input, because when you suddenly are not having your periods, you've done your pregnancy test and you are not pregnant, then you know that something isn't quite right. The second thing is the expression of the stigmata, as I put it, of the excess male hormones, where one might find that one has excessively oily skin, has extra bodily hair, whether facial, on the chest, on the back, or the buttock, or on the legs, in spite of, say, trying to shave or wax, or, it grows back very quickly, hair on the upper lip. And also, when people notice that they also have a lot of acne. So a combination of these skin conditions might prompt somebody to seek help. The other also very important thing that would trigger someone to seek help and investigation into PCOS is when they've been trying to fall pregnant and are not succeeding, despite having regular unprotected sexual intercourse, where the pregnancy is not happening. So all of these, or a combination of these, might give an inkling that PCOS might be an issue.
Thank you very much, Dr. Grace. Thank you so much. So, so you've mentioned what the symptoms are, and obviously you've touched on the inability to fall pregnant. So I wouldn't ask my next question then. And you've also touched on how medical professionals diagnose and let you know whether you have PCO or PCOS. As you said, you did the blood test and an ultrasound scan, and then the physical symptoms that you show as a person, and of course the inability to fall pregnant. In an earlier interview with you, the one we had last week, you did mention of the endocrine system. I'm not sure if I pronounced that properly. I'd want you to touch. Okay, thank you. I'd wanted to touch a bit on that. What is the endocrine system?
So the way God made the human body, he did it excellently. There are glands or structures in the human body who produce special chemicals, which are messengers. And they release these directly into the bloodstream to go to specific organs, what we call target organs. So if we recall, I spoke about something in our brains called the hypothalamus, which is then releasing a messenger to another organ called the anterior pituitary, which then releases messages to the target organ, which is the ovary. So you would realize that these messengers do not travel, by train or by flight. They go through the bloodstream to go and inform the target organ what they are supposed to do. So when we talk of the endocrine system, we are talking of the collection of these glands whose job it is to help the body to do its work as it should. And there are numerous systems in place. Some of them, they send their messengers through the bloodstream, as I've said. Some, they act very close to their target organ. So it's almost like, sitting close to somebody and them nudging you to give you a bit of information. So those are of a different name, but they all work in concert, giving out messages to target organs to help the body function as it should.
Thank you very much, Dr. Grace. Thank you. There's something probably I should have asked last week, but then once we are blessed to have you today, I will ask. Last week, you did mention FSH. Can you please touch on that? What is FSH?
So FSH stands for follicle stimulating hormone. Now, its work is in the name, follicle stimulating. So it's a messenger. Every hormone is a messenger. It comes from an endocrine gland. And this particular one, its job is to go to the ovaries and speak to the baby eggs in the ovary to ask them to start maturing. So the follicle stimulating hormone is released from that special gland in our heads called the anterior pituitary, and they carry one message. It's time for you to mature baby eggs. So it travels through the bloodstream to the ovaries to then instruct 5 to 8 of the baby eggs to start maturing. And when it does its work, the maturing eggs are then able to stop its action by producing another messenger, which goes to tell the original gland making it that it's enough, you stop. So that is what the follicle stimulating hormone, or FSH, is.
Okay, so if that is what it is, then if we say someone has hormonal imbalance, does that mean the FSH is not working properly, or what does it mean if we say someone has hormonal imbalance?
So as I said, the message is sent, and the target organ has to send a message back to stop its action. So the message goes to the ovary, but somehow, instead of the message being interpreted as 5 of you or 8 of you baby eggs, start, preparing yourself for maturity, the message is sort of picked up erroneously, so that you have multiple of the follicles getting to various stages of immaturity. None of them is therefore able to secrete the return message to go and tell the anterior pituitary enough of this. So the anterior pituitary keeps on pushing out more of the FSH because it thinks my message has not reached its endpoint. And so you realize that negative feedback mechanism, which should have stopped its action at some point, doesn't happen. And therefore, it is almost like throwing water in with a spoon into the sea to try and fill the sea up. That is the way it keeps going. So the dysfunction is basically in how that message is being perceived at the target organ, and how a negative feedback message is not being sent to the original gland to stop its action.
Thank you so much for clarifying that, Dr. Grace. In your submission, you did say that, which is obvious, one symptom of PCOS is when someone has unprotected sex and yet is unable to fall pregnant. I would want to ask then, at what age, what is the youngest age that one can be diagnosed with PCOS?
So PCOS becomes something that can be seen and diagnosed from the start of puberty. However, puberty in itself has a lot of these symptoms that we've discussed as a normal part of it. And so we do not go easily diagnosing 12, 13-year-olds with PCOS, because we wait until the normal puberty stresses that the body goes through has passed. And then if there is still irregularity of the periods, if there is still problems with, acne, hirsutism, or excessive hair, or if there is problems with being overweight, or the person is at a point where they are trying to have a family and they can't, that's when the investigation starts. But PCOS is something that can, start maturing right from the start of puberty. And on average, most girls would have had their first period by 12 years, which means that we can sort of look as far back as that time. The only thing is that medically, because we know there are other things that can cause the exact same symptoms, we do not give that diagnosis until the normal puberty issues have all been ruled out, and other conditions that can cause similar symptoms have also been ruled out.
Thank you. Thank you so much. Thank you so much. And God bless you for coming again today. We are so blessed to have had you. And we want to say that we appreciate you. We appreciate you taking time off your busy schedule just to be with us. And we hope that when we call on you again, you will come and share with us your in-depth knowledge on PCOS as much as the issue of infertility is concerned. Thank you so much. Viewers, we've come to the end of this week's session. Next week, God willing, we'll be here again. But then I would want to say that wherever you find yourself in your infertility journey, remember that you are loved, that you are wonderfully created by God, and that in His own time, it will happen. There is help available medically. So please speak to a medical professional and seek help early. See you again next week and take care of yourselves. Ciao.